Hello everyone, welcome to PhysioTriveda. Today we are going to learn one of the most important concepts in the neurology, upper motor neuron lesions and lower motor neuron lesions. Now let me ask you something. How many times have you studied this topic? Maybe during anatomy, maybe during neurophysiology, or maybe during pathology. And every single time you memorize the table, like UMN lesion means spasticity, hyperreflexia, Babinski positive, and LMN lesion means flaccidity, atrophy, and fasciculations. So you memorized everything. But when a clinical case comes in front of you, suddenly confusion starts. Like పేషెంట్కి ఇంక్రీజ్ రిఫ్లెక్సెస్ ఉన్నాయి, ఇది యుఎంఎనేనా, లేదు మజిల్ వేస్టింగ్ అనిపిస్తుంది, సో ఇది ఎల్ఎంఎనేనా, బాబిన్స్కి పాజిటివ్ అంటే ఎగ్జాక్ట్లీ మీనింగ్ ఏంటి, సో లైక్ దిస్. సో ఇఫ్ యూ ఎవర్ ఫెల్ట్ కన్ఫ్యూజ్డ్ లైక్ దిస్, సో డోంట్ వరీ, because today we are not going to memorize, we are going to understand the logic behind every single sign. And once you understand the pathway, you will never need to mug up with the differences again. Before learning the differences, let us understand why this topic is important. Many students think that UMN versus LMN is just an exam question. Actually, it is much more than that. Whenever a patient comes with weakness, paralysis, abnormal tone, or altered reflexes, one of the first question a clinician asks is this an upper motor neuron lesion or a lower motor neuron lesion? Because that immediately tells us where the problem might be located. Is it in the brain? Is it in the spinal cord? Or is it in the peripheral nerve? So this single concept forms the foundation of neurological examinations. So let us start from the basics. Imagine you want to pick up a water bottle. So it seems simple, right? But a lot of things happen inside your nervous system. So first, the brain decides to perform the movement. That command is generated in the motor cortex, and the signal travels downward through the nervous system. Eventually, it reaches the muscle, and then the muscle contracts, obviously. So this entire route is called as motor pathway. Now, this pathway is not made of just one neuron. It consists of two major neurons, upper motor neurons and lower motor neurons. And understanding these two neurons is key to today's topic. So let us begin with the upper motor neuron. So the upper motor neuron originates in the brain, primarily in the motor cortex, and their job is to carry movement related signals from brain down toward the spinal cord. Think them as a senior officers giving commands to the juniors. So they don't directly touch the muscle, instead they pass instructions downward. So now let's talk about the lower motor neuron. The lower motor neuron begins in the spinal cord or brainstem. This neuron receives instruction from the upper motor neuron, then it directly connects to the skeletal muscle. So if the upper motor neuron is the officer giving orders, so the lower motor neuron is the worker actually performing the tasks. So without the lower motor neuron, the muscle can never receive the command. So if you remember only one line from today's video, remember this. Like upper motor neurons means brain to spinal cord. Lower motor neuron means spinal cord to muscle. That's it. So if this pathway becomes clear in your mind, everything else becomes logical. So now let's visualize the pathway a chain. So imagine a chain. So the brain, and then the spinal cord, and then the peripheral nerve, and then the muscle. So the upper motor neuron occupies the upper portion of the pathway, and the lower motor neuron occupies the lower portion of the pathway. So now think carefully. So if damage occurs above the spinal cord level, we call it as upper motor neuron lesion. So if the damage occurs in the anterior horn cells, peripheral nerves, or motor nerve pathway, we call it as lower motor neuron lesions. Now let's move to the most important clinical differences. The first one is muscle tone. So what exactly is muscle tone? So muscle tone refers to the resistance offered by a muscle when it is passively stretched. So even when you are resting, your muscles are never completely relaxed. There is always a small amount of tension present. So that is called muscle tone. So now here's the interesting part. So the upper motor neuron normally controls and regulates the lower motor neuron activity. So you can think of it as a braking system. So the brain continuously sends inhibitory signals. So these inhibitory signals prevent excessive muscle activity. Now imagine the brake suddenly fails. So what happens? So suddenly activity increases. So similarly, when the upper motor neuron is damaged, so the inhibitory control is lost. So the lower motor neurons become overactive. So as a result, muscle tone increases. So this increased tone is called as spasticity. Okay. So that's why UMN lesions produce spastic muscles. On the other hand, in LMN lesions, the signal cannot even reach the muscle properly. So the muscle becomes loose or floppy. So this decreased tone is called as flaccidity. Next comes to muscle bulk. In UMN lesions, muscles still receive some neural influence. They are not completely disconnected. So therefore, muscle waste occurs slowly or usually maybe mild. So this is called disuse atrophy. So the muscle becomes smaller because it is not being used effectively. Whereas in LMN lesions, so the situation is completely different. So the muscle loses its direct nerve supply. So without nerve stimulations, muscle fibers begin to degenerate. So as a result, wasting becomes much more severe and obvious. So this is known as neurogenic atrophy. So remember, mild wasting present means think of UMN. Severe wasting present means think of LMN. Now let's talk about the reflexes. So this is one of the most important examination findings. So a reflex, so generally we call it as a spinal cord activity. Okay. So when a tendon is tapped, obviously the response occurs through the reflex arc. So normally the brain regulates these reflexes. So again, we said like that brake example. So think again of the same brain applying brakes on the neural activity. So if the upper motor neuron is damaged, so those brakes will disappear. So obviously the reflexes become exaggerated. So this condition is called as hyperreflexia. When examine the patient, you will notice brisk reflexes. So now in LMN lesions, so the arc reflex arc itself is damaged. So it is like cutting a electrical wire. So no matter how much you stimulate it, the response cannot occur properly. So therefore reflexes becomes reduced or completely absent. So this is called hyporeflexia or areflexia. Okay. So now let's discuss fasciculations. Students often get confused about this. So fasciculations are small, visible, like involuntary muscle twitches. So they appear like tiny ripples under the skin. So now tell me, like, why do they occur? Because they occur because obviously damaged lower motor neurons becomes unstable, so they start firing spontaneously. So this abnormal firing causes small muscle contractions. So since this phenomenon originates from the damaged lower motor neuron, so obviously fasciculations are typically seen in LMN lesions. So they are not a feature of UMN lesions. Okay, so now let's come to the favorite exam question, so the Babinski sign. So in a normal adult, when the sole of the foot is stroked, the toes curl downward. So this is the normal plantar reflex or else a plantar response. But when there is an upper motor neuron lesion, the greater toe moves upward. So this is called as extensor plantar response or positive Babinski sign. So a positive Babinski sign indicate loss of higher motor control. So therefore, whenever you see a positive Babinski in an adult, think about an upper motor neuron lesions. Okay. So now let's apply everything what we learn. So imagine a patient comes to you after a stroke. On examination, you find increased muscle tone, brisk reflexes, and positive Babinski sign. So immediately your brain should say this looks like an UMN lesions. Now consider another patient with a peripheral nerve injury. So you observe flaccid muscles, severe muscle wasting, and absent reflexes or hyporeflexia. Okay, so or also with fasciculations. So now your diagnosis should move toward an LMN lesion. So this is exactly how clinicians think. Okay, so now I want to give you one line that can save you during exams and clinical postings. So that is simple. It's like UMN lesions equals to loss of control, and LMN lesions equals to loss of signal. So UMN means loss of control, LMN means loss of signal. So loss of control obvious produces excessive activity, and loss of signal produces reduced activity. From this single concept you can derive almost every difference. So that's the complete concepts of upper motor neuron and lower motor neuron lesions. So, if today's explanation helped you understand the logic behind these differences, make sure to support the channel, subscribe to Physiotriveda, and share this video with your classmates, because this is one topic almost every healthcare student struggles with initially. So, thank you for watching. I'll see you in the next video. Jai Hind.